All right, it's still us. And yes, today you get to listen to Kurt talk at you. So first reschedule, San Quinones is now going to be on November 9th. So not next week, the week after. His paperback of The Least of Us comes out next Wednesday. And so that's pretty cool. I guess you can all go find that copy somewhere and you'll have a whole week to read it out of the paperback version. And so yes, if you have other people you may know that might want to get on and listen to him, because I'm still super fangirling and I can't believe I have to wait an entire extra week to meet him, but I do. Okay, other things coming up. So we can see today, next week, like Kurt just mentioned, Charlie is coming back. Dusting, spray, misuse, Enroll America. And this is like computer cleaners and just so it's kind of like a huffing thing. But I guess it's pretty exciting and interesting. And so you can see we get all the way through the end of the year. No echo the Wednesday before Thanksgiving. And then Christmas, New Year's fall in like the weird weekendy thing. So we are going to take a little bit of a break around there and then come back in January to celebrate our ridiculous 5-year echo anniversary. I can't believe I've done this with you for 5 years.
Been the best days of your life.
Okay, turn on your videos if you don't mind. Kurt again is presenting and he doesn't do well with any type of, silence or electronics without faces.
A lot of anxiety.
If anyone's surprised. You can chat in questions. We'll see if it's applicable to that exact moment, if Kurt wants to get interrupted or just wait till the end and let us know, obviously, if there's more than one person in the room. And we're all, of course, always here for you. And I say all, I'm referring to Aaron as well. You can get our contact information. You can call us, text us, email, whatever. It's easier for you on any type of patient case, or if you even want connections to anything or the manual, which is still not on the website yet. Finally is getting clearance. But if you would like any parts of it, you can reach out. We can send those to you as well. The addiction connection, pretty soon this logo is changing and you're going to have to see our faces on the logo. It's going to be fabulous. Yesterday was the last installment, the finale of the sugar addiction.
Thank God.
It was a good one. It's super fun. And people liked it better than your suicide ones. Let's just be real about that.
Barely.
Sugar is way more fun than suicide. Clearly.
Yeah, well, clearly.
So, all right, so Kurt gets to present it.
So this is kind of a fun talk. I really enjoyed, I kind of ran across some of this stuff and it decided to turn that into a little echo. We did this on a Tuesday echo months ago, so I kind of revised a couple of things and got it back going again. But we're going to talk a little bit about opioid prescribing, kind of that increases that risk of overdose, and kind of why the aging process is kind of an issue for that as well. And
I've heard a lot of aging issues.
Yeah, and there's none that I know of. And review some of the co-prescribing risks and adverse events, things that that we will see as a part of this whole problem. So, am I going here?
You can.
Well, nope.
Let me just get you onto the slide.
All right. So prescribing opioids to older adults, again, we're going to be talking about just things to consider. Now, I'm just going to start by saying that the reality is there's kind of this ladder of things that we think about as we give analgesia to patients, and really always looking at the non-opioids and some of the weak opioids, what we call partial opioids, things like tramadol and such, which of course also comes with risks. But we don't want to move into the more potent opioids until we've tried other things. And of course, most people can get by with the non-opioids. That would be the hope. One of the things that we always have to consider is that as people age, there's also other things that occur. And if we look at just simple things like cognition, cognition could be an issue for how people understand what you're telling them, even how they can maybe hear you when you're giving instructions. They may not completely hear you. And I can't really see that last one, Heather. Oh, visual impairment. Sometimes things can be difficult to read. And you have to make sure that it's very clear for patients that what you've written out is actually legible, because patients need to understand their instructions. And I think most of us have probably seen people who've come back and they're taking medications not as you intended. They've doubled up on them or done unusual things. So
the hard part right now is me just not making fun of you this entire
Yeah,
talk.
I get that. So as a result, again, medications can be taken incorrectly. They may not understand things that were actually discontinued while others were started up, and they'll be taking both. I've had patients who were taking two medications for the same problem and didn't realize it, and they may need some assistance actually setting these up, which of course puts them at other risks, especially depending on who's setting up their medications. And we've had some interesting stories with that over the years.
So to answer the question about the drum kit for the jokes, on our podcast equipment, we actually have a button. Although most of Kurt's jokes get the button that goes wah, wah.
Yeah. Jennifer, just hang in there. This is all fun. And this is all fun. So first question is really, does the formulation and the dose of a long-term opioid therapy contribute to the risk, right? As far as older adults, does that increase our risk? So we're going to talk first just a little bit to prelim this by.
You said our.
Prelim this with kind of why people be on opioids. And really in this age group, it's this chronic non-cancer pain. And it's really quite prevalent. So when we look at people with pain, it can often be disabling as well. And if we look at just statistically, 3 or 4% of adults are receiving at any one time long-term opioid therapy. So again, this is a common thing in patients that you're going to be seeing. We know that patients who take the highest doses are actually more likely to have adverse events. And if we look at people getting the highest doses, a lot of times it's these older adults. And 3% of the older adults are getting more than 120 morphine equivalents. So we have to be very cognizant of these patients as far as their risks. And again, we often talk about legacy patients. And is it okay just to leave them alone? But I hope that after this talk, you'll kind of look at that and say, are they really that safe?
So I have a question
Yes.
with reference to this, and anything you saw or just something for people to think about is, why are they at the highest doses? Is it because they are these legacy patients and over time the doses just kept going up and up and up because one, their actual, pain generator that they acknowledged wasn't worked up and treated in a different way, or just the tolerance kept building. And so I think that to me is the biggest, is how did they get there?
Yeah, and I think often it's tolerance. They come back in, their pain's returned, and thus the opioid epidemic, right?
And the average number of years those patients were on opioids is probably ridiculous.
Yeah, it probably is. And probably in the last month, I've seen 2 different women who are on for more than 10 years. So it's very common. So why do older patients have more risk? Well, I think we all know that things change as we age, and really as you age, because Heather's turned 40 this year, they get reduced renal, hepatic, and respiratory function. And of course, when we alter the metabolism of these medications, it's going to contribute to adverse outcomes, especially if it's not recognized that things have been changing. And again, there's going to be some other things we'll talk about today that'll also play into changes in renal hepatic function. So let's get back to, does it make a difference if it's long or short acting opioids? This is very clear. Yes, it is very clear. And I think that the important thing to understand, and this has been written about a lot, this was in the CDC guidelines, is that the long acting opioids are associated with double the risk of overdose compared to short acting, especially when we're looking at naive patients who suddenly are given a long acting opioid instead of a short acting opioid right from the gate. So what's really been unclear until recently is how is this in comparison with older adults? And by older, I'd say 65 and above. It's a group that I'm not familiar with quite yet.
Just a couple of years.
Yes, just a bunch of years, lots of years. So this was actually a good study that was done just about a year ago that just finished up. And this was about really the opioid dose and formulations in older adults, something that in older adults had not really been looked at that closely. And they actually looked at patients over 65 who had chronic non-cancer pain. And really what they were looking at for adverse outcomes was the opioid-related respiratory depression, which we know these patients are at higher risk for, and opioid overdose, as well as and I really like this when they do these things with all-cause mortality, because a lot of times it can be vastly different. So what they found in this study that was really the use of these long-acting opioids significantly increases the risk of overdose. and also all-cause mortality when compared to the short-acting. So it's important to understand that in the older adult, this can be a significant life shortener as far as the risk of overdose.
Okay, I'm going to comment on that really quickly. And this is where I think we run into a lot of issues currently, just in this more recent opioid epidemic, when it's opioid stewardship. Because even in my generation of provider, which we tend to provide or prescribe less, generously. No, there's nothing else.
Okay.
I was taught in residency that no patient should be on long acting, with the PRNs would be like infrequent short acting because it was less abusable. It was, they didn't have the highs and lows. And so changing not only prescribers from other generations, but even the younger generations, we were taught this differently. And so that is something to just keep in mind.
Yeah. So, and I'm not sure what that is referring to.
Long acting.
That would, because the lower risk of
we're talking about Butrans, so the buprenorphine.
Yeah, buprenorphine, which is that is not in the same category because of it being a partial opioid. So because it does not cause respiratory depression in the same manner as the oxys and those things, I don't think that would be included. In fact, one of my other talks, I had a little study in there which showed that you could even take opioid naive patients and give them 32 milligrams of buprenorphine without any significant respiratory depression. So I think that we'd have to probably leave buprenorphine out of that.
Yeah, this is more the ER, the like morphine, extended release, and OxyContin.
So if we look at the dosing, and these are pretty mild, 20 to 50 MME and 50 and above, even these are risk factors for all-cause mortality at this level, and really, much different than those patients that are under the 20 morphine equivalents. And I think we say this all the time. I know Charlie says this all the time, that there are no safe doses of opioids. And often, again, in this age group, if they accidentally take extra doses or they're using other things with it, which we'll talk in a moment about, there's really no safe dose. And this has been a very consistent thing in most of the studies. And again, looking back at the CDC guidelines, we know that there's a level where there's much higher odds of problems. And again, that's that 90 to 100 morphine equivalents that seems to be that area. And again, that's been shown in multiple studies. So what are the cause of increased risk for older adults with these long-acting? What is really the issue? And often it's this decreased renal function, liver function, and the fact that they don't clear these medications, right? So again, I had this on a previous slide. I repeated it again for emphasis. I thought Heather would pick up on the fact that this was repeated. And
no, I think Katie put that asterisk to make fun of you because she had to do it twice.
Yeah, it's not my cognition that makes me repeat. I just think it really bears making sure that we check these things, especially in patients who are on these particular medications. Remember that the renally cleared opioids, typically morphine, hydromorphone, and one of more historical, I think, meperidine, which we don't see used that often, but back 10 or 20 years ago, that was a commonly used medication. One of the things that we think about sometimes when we see patients and they have some significant renal issues is switching potentially to something like oxycodone. And if we have issues as far as liver insufficiency, considering things like fentanyl or hydromorphone. So we need to kind of understand that as these patients age, that we may be, if they are on opioids for a reason that they will need to continue, we need to think about different types of function. So let's talk a little bit about association of the average daily morphine milligram equivalents and falls, because if we look at the older adults who are chronically using opioids, falls has to be a big part of our conversation because it is a significant risk for this patient group. And really, when you look at falls in our country, it really is one of the leading causes of fatal and non-fatal injuries in older adults. I mean, think about it, 800,000 hospitalizations every year due to older people falling, 27,000 deaths. So about a fourth of what opioid overdose or overdoses in general are in this country as far as death, but still a pretty significant amount of people die from falls. And what puts them at risk is important. If we look at the fall data, even from 2018, and if you've ever fallen off a ladder, it stings a little bit. 27% of people, almost a third of people fell at least once of older adults, and 10% had significant injuries. So it is important to understand that without opioids, without alcohol, without all these other things, people fall. And older adults fall more often because of multiple reasons. We often talk in family practice, when we used to do family practice, about prevention of falls, and we'd have conversations with patients about what was in their house, the throw rugs, all these things. But think about their medications, and we need to be looking at people's medications, and probably more specifically the opioids, and whether or not the dose of their opioid can really affect the fall rate. And that's something that until recently had not really been looked at. And so does the opioid dose really predict it? Until recently, again, no studies. But it was interesting as I was doing a little research on this. There was actually she was a PharmD student, and I'm not sure how you would say her name. I believe it's Stephanie Wang, and she actually did this as her research project for her part of her education, her PhD, or to get her PharmD. And she did a whole study doing electronic medical record review of 10 primary care clinics. And what she looked at was actually just patients who'd gotten 4 prescriptions of opioids per year. And she looked at their average MME to try and compare them, and then decide, is there a level where patients tend to fall more? And it was actually a really interesting paper that she wrote. And she came to the conclusion that really, on average, if you get above 37 morphine equivalents for non-cancer pain, they basically had 50% greater risk of falls than people under that. And so we need to kind of look at that level when we're talking about patient falls. So 37 morphine equivalents would literally be about 20 oxycodone per day total. And above that, they're going to have a little bit more trouble. So let's talk about co-prescribing a little bit and risk of falls. And actually, a lot of this work has been done looking at hip fracture studies in older adults. And really, it's pretty interesting when you look at co-prescribing. And we talk about this a lot, about benzodiazepines and opioids together, and the risks with just people having respiratory depression. But I think that we have to think about how many of these patients also have falls, and some of the hip fracture data really kind of brings some of this out to the forefront. If you look at these patients, and they looked at patients over 65 years of age, they actually looked at 287 patients who had hip fracture. And this was with 574 control patients. Interestingly, and not surprisingly, about 72% of these are female with an average age of about 82. And when they looked at what percentage or what happened when patients were taking both opioids and benzos in that month prior to having the fracture, it actually increased their risk of a hip fracture by 4 times. And so, again, this is a group that we need to be very careful of. We need to understand that the benzos and the opioids are not just an overdose risk, but they're a fall risk. And remember that people who fracture their hip, it certainly has a great effect on how long their longevity, how long these patients can live, and what's the mortality after a year of a hip fracture. It's relatively high. So it's not just overdose that will end up causing significant mortality and morbidity. So let's talk a little bit about co-use of benzos and opioids in chronic pain of older adults with falls, fractures, and ED visits. And it's interesting when we look at what happens, does these overlapping prescriptions, do they increase the odds of falling or visiting an ED? And really, when they did this, they actually looked at 517 adults, and they looked at a private health system, a VA system, to kind of look through these charts. And it's interesting because, much like what we were showing before, about 25% of these patients on opioids were actually co-prescribed and got benzos. And they had adverse, and 25% of these people had significant issues, 3 times greater number of falls, 1.5 times greater number of ER visits. So again, benzos and opioids, not just an overdose problem. It's a fracture problem. It's an ER visit problem. It's an injury. It's an injury problem. Now, this is one of the things that often doesn't get enough time set aside for it. And I think working strictly in addiction clinic now, I've been surprised about how much alcohol we see in patients both taking Suboxone and patients actually on opioids coming in needing help. But alcohol is a pretty common issue. And of course, as patients age, it becomes even a little bit more of a significant problem. They're often used together. And if we look at alcohol as far as overdose deaths, often even when opioid might be the cause of death, we'll find that alcohol plays a significant part of that, of course, because they're both seen as depressants. There's actually, especially in the older age groups, there's not a lot of research on this. And frankly, digging around, it was really not a significant number of papers that have been done.
That picture of that gentleman is you aged 20 more years.
Yeah, no, I look way better. So the majority of patients with opioid use disorder have some other chronic diagnosis. And I think it's surprising that a quarter of those, that diagnosis is actually an alcohol use disorder. And so it should be something that we're thinking about, 25% of the time, that patients that we're seeing with opioid use disorders, we have to screen them because a significant number are either starting to drink and developing another use disorder, or they're currently drinking.
And that's got to be harder, like with older people with chronic opioid prescriptions. Many of them don't see that there could be an opioid use disorder there. Moderate opioid use disorder is not that hard to, achieve if that's a goal, a diagnosis for. And so it is super important.
Yeah. So this was a study I actually did by Kaiser, and they actually looked at 11,000 patients that they had on opioids in their system. And this is, of course, people only with having an alcohol use disorder as a diagnosis. That doesn't mean that there weren't more patients who actually had an alcohol use disorder that had not been discovered. So still, that's still 1 in 10 at the minimum. And again, often we're seeing patients who are having issues that are not discovered, they have not been screened, or they're very quietly going along drinking. So actually a pretty similar study, they had almost 1,000 patients who were on chronic opioids, and they were surveyed. And it's surprising to me that when we look at this on patients on chronic opioids, that almost 6% of people are having more than 10 drinks per month. And of course, it didn't go any higher. So the question is this daily drinking? And it's interesting that if you look at, and there's another study I'll show you in a second, it's actually in most developed countries, it's probably pretty high. And if we look at patients who come into treatment, so patients that are coming in for an alcohol use disorder, half of these people have a history of moderate to severe pain. And just like one of the ladies that I saw here in the last month, she was drinking because it helped her pain. And so we see people that will use alcohol for their pain. So not surprisingly, people with alcohol use disorder have a history of pain. So what makes it a bigger issue in older adults? Well, again, it's the changing physiology as we age. I'd be in the middle there. And changes cause
or right there.
Changes cause kind of the following problems, right? People get a much higher blood alcohol with each drink. And as we've seen, for instance, in patients, so what's happening is they'll sometimes get an alcohol level will come up much more quickly. We talked about this actually with patients who'd had a stomach bypass, who'd had Roux-en-Y's. Their alcohol levels will go up very quickly. And in fact, it's linked to more alcohol use disorder, much like this. So they have more impairments in their balance, their slower reaction times, they have worse driving skills, their memory deficits. So all of these changes occur. And then when we put alcohol on top of that, that's what really increases our alcohol-related harm. So I think it's important to understand that we're already got physiologic changes that put people at risk of falls, accidents, and forgetting things. And then we add alcohol to that. And are they going to take their opioids twice during that day instead of once, or 3 times instead of twice? So lots of different ways for this to become a problem. So in older adults on opioids, how often is alcohol a concern? Well, this is what I was talking about a little earlier, that in developed countries, 90% of patients over the age of 50 drink alcohol, 90%. And if you look at the United Kingdom, which probably isn't too different from here, 20% of that group was consuming at what would be considered hazardous levels. And so we have to probably extrapolate that to our patients, understanding that a lot of the opioid patients are probably drinking in a hazardous way, especially with the medications they're taking. I literally an hour ago had a patient whose mother was drinking heavily, took all her pills, and died 3 days ago. And so we have to understand that this can be a big issue. Actually, the AMA did a study that showed that when we think about alcohol consumption, that's really the group that seems to be consuming more over the last 10 years is actually the people 65 and older. And so, although often I don't think we find ourselves screening that patient group, it is the group that is really escalating. And it's
they're having some
to.
really good parties because the rest of their healthcare is so good. They're at home and just hanging out.
That's right. And I think that this is probably also a group, if I think back to my parents who are now in their 80s, it was very common for that age group to have the highball at supper, to have that drink before supper. That was just the common thing. And that drink turns into 2, into 3, and as they age, it becomes more of an issue. Just to put alcohol in perspective to other health problems, as we think about how much alcohol people on opioids are drinking, older adults are actually in the hospital for alcohol-related problems as often as people with heart disease. So this is a really common problem.
And that's alcohol-related problems. It doesn't necessarily mean they're all in there in detox. It's
correct. Alcohol-related.
Cirrhosis or some type of other things.
Yeah. So the bottom line on alcohol and opioids, really, if a patient needs opioids and they need to continue them, you need to talk to them about their alcohol intake. I think that's super important.
It's like our catch line on the podcast. You actually have to talk to a patient.
Yes, you need to talk to them and counsel patients about the risk of co-use. And honestly, in the last week, I've probably done that 2 or 3 times, even on patients with Suboxone, because probably a third to half of my patients on Suboxone do occasionally drink alcohol. And I ask them about it because I want to make sure they understand it's probably not a great idea. Anytime we see somebody in the hospital with a fall or an overdose or anything, we need to have that discussion. Are they drinking more than we think they are? We need to screen them for an opioid use disorder. We need to screen them for alcohol use disorder. So what we're going to do, this is one little thing that I found interesting that I threw at the end of this talk, because often when we talk to people about prescribing, again, there is a group of people that would say, if people are stable on their opioids, we probably shouldn't change a thing. And I've always been, and I think Heather's been for, the lowest effective dose if they absolutely need them, because that's the safest. And actually, there was a very interesting study done by Dr. Doctor, if you can believe that, back in 2018. And they were looking at what prescribers did after they learned about one of their patients dying from an overdose. And it actually monitored the effect of notifying physicians that one of their patients had died of an opioid overdose if they were actually prescribing the opioids to them or had in the last 12 months. And then they would send the provider a little warning and just say, listen, just so you know, one of your patients overdosed and died, and they died of an opioid overdose. And the control group received no letters. And they did this with almost 900 clinicians. And what they found out was this little letter changed the prescribing of these physicians substantially, made them much safer. They did much less high-intensity prescribing. They reduced what they were giving opioid-naive patients. And there was a significant reduction in their cumulative opioid prescribing to these patients. And so the bottom line for me really is, boy, don't wait for somebody to die that you're caring for. It's really... I think we need to thoughtfully look at our opioid prescribing all the time. And I think that's something that I took very seriously, because these medications, especially when mixed with other things, can be a problem or on their own. So understand that bad things happen, but we need to be the safest we possibly can be. Now, there was one question there, and I couldn't see the other one. If we want to do questions before we talk about this case. So
I got it.
Okay.
Let me run this.
Okay.
No, so the question about Tylenol number 3 and the renal. So it's metabolized to the liver into morphine, but then codeine is like it's renally excreted. And they did they comment that like 5% of codeine is actually excreted as codeine. And so there can be accumulation. So really, if you look at the guidelines for Tylenol number 3, there's cautions for renal insufficiency. There's cautions for hepatic insufficiency, especially with the Tylenol. But codeine can be liver and renal. You need to watch. And I just don't love codeine.
Yeah.
A question about methadone and stable. These would be your, legacy patients. For me personally, methadone in general has so many interactions and side effects and troubles. And if you start messing with the metabolism as patients age, they're also usually on more medications as they age, and therefore more interactions or, any cardiac changes. I would definitely, 100 milligrams of methadone, I don't know what the morphine equivalence of that is, but it's not low. So I think it's the whole purpose of this talk, at least I've heard it a couple of times in podcasts at once, but it's really being aware of it and making sure you're assessing it. And it's hard, like having that conversation with that patient who's been stable on it for 100 years is, there are other things going on in your body that you don't have control over. And, this patient safety thing would be tapering or doing more of a workup or different treatments.
Yeah. And I think the thing also is that it's that shared decision-making, right? We talk about this, when we look at some of the report card stuff that we get about, chronic pain patients, it's really understanding and having that conversation with the patient, especially with methadone. And again, I think one of the issues as people age is the different things that interact with it. I never did much methadone, although there's quite a few people in my clinic that did. But I think it's really having the conversation and can they have less risk of other problems if they come down? And of course, making sure that the diagnosis that they have for chronic pain is well documented and their improved function is well documented.
Right. So the diagnosis of chronic pain is no longer an official diagnosis for long-term opioids. Right. I love this, Abby, about adding that to the Medicare wellness, the screening for alcohol and opioids, because that wasn't in here. And we talked about it on the podcast, and I was going to interrupt and I forgot, is asking about this. It can be hard to ask grandpa and grandma when, that how's your alcohol, and to really get into those questions, but it is super important. So, having that screening tool on there is great. Wow. 1,200 morphine equivalents. Thanks, Chris.
Yeah. So that, and of course that's relatively
a small number.
Yep. So
anyway.
So yeah. So I'm just going to talk for a moment about this case, just because it's kind of related, but it's more alcohol use on the beginning side, and we'll just kind of people can chat in any comments about this. This is a lady that I just saw here in the last few months, and I got a phone call from the pain clinic, which is always scary, and they wanted me to see this patient, and she was going to be seen for the consideration of buprenorphine treatment for chronic pain and a history of alcohol use disorder and a vague history of opioid misuse, and didn't really carry the diagnosis of an opioid use disorder. And to be honest, this is a little bit out of what we normally do, but they asked for help, and so I had them send her over.
Not out of what I do.
Well, yeah, the alcohol use disorder was not, but buprenorphine treatment for her pain. So she shows up, and they felt that her alcohol use disorder needed to be addressed before anything else. And yeah, she had a past medical history, which was amazing. It was an entire page. But these are the high points. She had cervical and lumbar fusions. She's basically fused from her neck to her tailbone. And she's one of 2 patients I have with that particular problem. And she'd had previous withdrawal seizures on alcohol. She had interesting recent labs showing normal LFTs and renal function, which again, we want to know in an older patient. These are the 4 medications that this group would care about. This is what she was taking for her chronic pain and her sleep and such, and her anxiety. And she was a very anxious lady. And she's clearly got a little issue. She's drinking 3/4 of a liter of vodka a day, which her partner goes and picks up for her. And she's smoking a pack of cigarettes a day. So I guess the big first question is, is she a candidate for buprenorphine? I don't know if people have thoughts, if you can unmute or you can chat it in.
My one comment with to make sure we at least keep in the back of our minds, looking at her liver and renal functions, is people with severe liver disease can still have normal liver functions or normal LFTs, which actually isn't a function of the liver. And so a person with chronic alcohol, you might want to get the other things like an INR, for instance, or platelets. So something that the liver actually does, because that can be a false normal. And, their liver might not be functioning, but the LFTs won't be elevated because they just can't be.
So no one's going to comment on whether they put her on buprenorphine today.
Give them a second to unmute since I talked.
Isaac says, no way, Jose. And yeah, I didn't. It was a very interesting visit. So what would you do first? What if
she says to you, well, I can't stop drinking because of my pain, which is what I've heard. And so it's kind of what comes first, the chicken or the egg, and weighing the risk benefits of, do we do buprenorphine with alcohol? Do we not? What do we do?
Yeah. And, buprenorphine, as far as respiratory depression on its own, is not such a big issue. But of course, we mix alcohol in there, and there's really not great studies that I am aware of. But I prefer not to do it. So what I did today is I said, listen, there's lots of different things we can give you that might help decrease alcohol intake. And as some of you may recall, we did the alcohol talk a month or two ago and talked about some of these medications, but understand that even naltrexone has modest improvement in people's drinking as far as how much they drink and such. It's not like, oh, we're going to give you naltrexone and you're going to stop. And of course, if she's going to be considered for Suboxone, that's a whole nother discussion. I discussed her going to inpatient treatment, which we do right here on Marth Lore.
That's not inpatient.
Treatment. It's not, she wouldn't do inpatient, but she wouldn't do outpatient as well. And then I talked to her a little bit about the circumstances under which I would give her buprenorphine. And of course, that included the fact that we needed to get her drinking under control. And so the first thing about which medication to use was really my big discussion with her. And to be honest, this woman was crying during half of this visit. She was very angry that no one would give her opioids for her pain. She was drinking to make the pain away and made it quite clear she would not be drinking if she did not have pain. Now, the other thing that I'm going to tell you is that she also had a severe history of trauma, and in fact had been sexually assaulted and abused by her grandmother, which I had never seen quite this situation before. So her ACE score was quite high, which I found very interesting in view of where we were.
I want to go back to our med list if we're going to talk about meds, just because that might help people. Yep. So is that where you're getting? Sorry.
Well, no, I think that, so that's just the conversation that I had with her. So my next conversation with her was, which of these medications might be best for her particular situation? Does anybody have a thought? Which one of these they might use? And again, we did talk about this a few months ago.
In addition to the 4 other mental health meds she's on?
Correct. And one of the issues really for her is that my goal is to get her on buprenorphine for her pain. That's my goal. And so that really made naltrexone not the choice. And so I had a long conversation about topiramate, which in some studies has been as effective or more than naltrexone, especially for decreasing drinking and other things, and meth use. So we had a long conversation about this, and I started her on that prescription. And actually, that was a good point that Isaac just made about it might be helpful for her pain as well. So it was kind of a twofer.
And naltrexone can help with pain.
Yes.
You use that low dose too.
Yep. But it was kind of off the table because I was heading toward buprenorphine. So I had a long conversation with her, and she agreed to take the topiramate. So let's fast forward a couple of weeks. The patient comes back it's amazing. Her cravings for alcohol were almost gone, just minimal. She started the topiramate at a very, very tiny dose. A lot of the studies with topiramate for alcohol are around 100 twice a day, 200 twice a day, much bigger doses. She tried to increase it, but it made her too sleepy. But she'd literally not had a drop of alcohol since I had seen her, and amazingly had no significant withdrawal symptoms, potentially the topiramate helping with that as well. So it was really an amazing turnaround. And so she comes in 2 weeks later, has not drank alcohol at all. And actually, I believe I had him do a breathalyzer on her that day, and it was completely negative, just to be sure. So what was the outcome? I just saw her back last week. She tried to take the buprenorphine, and it made her so sleepy and groggy she could not take it. Something that I have never seen at this level. We've occasionally had people get a little tired. So then I switched her to buprenorphine alone.
What dose did you give her?
2 milligrams twice a day. Very tiny dose. And so I tried to switch her to Subutex. Same problem. Could not give it to her. She's now 6 weeks out from alcohol. Still no cravings whatsoever on the topiramate. Does not want to change the topiramate. Sadly, I had to send her back to the pain clinic because there was really, do I think she's a candidate for opioids? I probably do not. I think that unfortunately, this woman would probably overuse. So we'll have to kind of see.
Yeah, that's our nurse. You can say what they did.
Yeah, and actually my nurse just did in the pain medicine clinic, started her on naltrexone, low dose for her pain, which now, since we're not going to do the Suboxone, works out perfectly. So she's got two things to help her not potentially restart her alcohol, and she's done the naltrexone for her pain. So very interesting situation where we've got alcohol involved with an elderly person who also has pain. So I don't know if anybody else has other comments.
Suboxone, how did you tie that to a diagnosis? Because that would be off-label for pain.
Good question.
Did you put that, or did you tie it to her history of possible opioid misuse? So how did you do that?
I put it off-label for her pain. Yeah, and understand that if you're using, Suboxone, Subutex, any of those things for pain alone, because she didn't have a true opioid use disorder, I explained to her this was off-label and documented that for pain. So, any other comments or questions about that case? It was really an interesting case how you kind of got to roll with it with each patient. And
how was her anxiety?
Her anxiety was markedly better. It was amazing how much better she was overall to talk with. But she was a lot less emotional when she wasn't drinking. So I think that helped in a lot of ways.
Did you ever think about trying Belbuca?
I don't have a lot of experience with that. I thought that the clinic might consider that. But I'm not surprised that they went with naltrexone. I mean, she got so groggy, she just couldn't function. She could hardly stay awake. And that's what her caregiver told me. So I'm not sure that they would try Belbuca based on that. Yeah. It's good thought though. Yeah.
Hey, Kurt, it's Isaac. Really interesting case. Thanks for sharing it. Did she comment at all on her pain after she had stopped drinking, what she noticed?
She still felt her pain was really, really bad. And I don't know, I never really have them give me numbers, but she would get tearful talking about it. To be honest, I felt like she didn't act as uncomfortable as she had previously. I mean, when I saw her initially, she would bring up her pain once every 90 seconds. And when I saw her back, she was so much more clear and so much more, her cognition was so much better. And we could have a much better conversation, but she was just adamant that somebody had to help her with her pain.
Mm-hmm. Yeah, I would just say it's not often, but it definitely happens where we get the sort of, if you would take care of my pain, then I would quit drinking kind of thing. Or, there's that, or also the kind of sort of threats about suicide, right? Like if, I'm going to kill myself if you don't do something about my pain. And it just really sort of shifts the responsibility about the pain management is what the the patient's trying to do. And obviously there's a lot of distress with that, but especially for the alcohol ones, and in this case, I think really exemplifies that, is that it's just that has never been my experience that people will stop drinking if their pain goes away, or they'll stop doing X when my pain goes away, because that is such a nebulous outcome, and really difficult. And most of this stuff, there's a number of reasons that they're doing it besides just the pain. Like you mentioned, really significant trauma history, and really just trying to check out of any feelings in the body. And so I tend to talk to patients about that I think we need to treat your pain in addition to treating your alcohol, or do it at the same time. But it won't work for us to treat your pain first and then, your heroin use or your alcohol use. It really needs to be at the same time. And that sometimes goes a little bit easier if they feel like they're going to get kind of both things at once. But it's just, you'll never get ahead on the pain if someone has a really significant active addiction problem.
It's funny you say that, because she said that to me. She said, if you get rid of my pain, I wouldn't be drinking at all. And I was like, yeah, I'm not 100% sure on that. Let me ask you, Isaac, this patient shows up to your clinic and she clearly has pain generators. Would you ever consider opioids on a patient like this at a low level?
No, I mean, probably not. I guess it depends a little bit on what the pain issues are, but the part of the issue with the opioids, and it's just like the alcohol too, is that it's just another way for people to disconnect from their bodies, and it just actually can really make it more difficult for people to move forward. And again, without knowing her particular case, that may be something unusual, but almost always we're trying to get things so that they can start feeling things and then dealing with the emotions that come up with that, and trying to separate the suffering from the actual kind of physical feeling of the pain. So I honestly don't remember the last time I started opioids on someone that wasn't already on them, that I was just trying to convert to something safer.
Yeah. And actually, I'm seeing her about every month and a half or so. And my next step is to try and get her into some type of a counselor. I'm trying to get to know her well enough that we can breach that again. She had never told anybody. And I started asking her about that, about sexual assault or any of that kind of stuff. And when the grandma situation, and it was a tragic, horrible story, that I've never heard anything like that. But it clearly, I think that would help her mentally, probably more than medication, to actually deal with that. So even at her age. So yeah, great case. Very interesting. Any other questions from anybody? Thanks so much, Isaac. All right.
I don't know, is there another case or no?
Oh.
Go ahead, Isaac.
Oh, yeah, it wasn't related to this, but I was kind of curious on your thoughts. We run into this at the hospital a lot, where someone maybe isn't on opioids, but is drinking a lot, elderly, has a fall, breaks something that hurts and gets a surgery, doesn't want to do treatment, and then we're supposed to send him home. And the question is always, do you send him home with something? If they're sort of don't think their drinking is a problem, even though they just had some related injury to it. And then they have something that, typically we would use opioids for, how much ever time after some orthopedic surgery. I don't know if you ran across anything in the literature about those types of situations where it seems like in most of the time we would use opioids for these kind of acute things, but the risk factors are really pretty high for that person.
So in terms of the literature on that, there's like a couple case studies, because I did this on a patient who, not that it had a fall related to the alcohol, but a person who's in long-term recovery from alcohol and was having hips and knee replacement and all of that, and like adamantly refused to be on a pain med for the risk. And so did a lot of research on what do you do in a patient who is high risk, whether it's due to alcohol or opioid use disorder or something. Like, what do you do for acute pain? And there's like hardly anything. So I use the buprenorphine, I use Suboxone off label, noting like I tied it to chemical dependency. Like I tied it to like a very vague use disorder history, not necessarily opioid use because didn't have it, but, and it worked remarkably well for pain, not needing any other type of opioids, like post-knee replacement, 5 total doses in a week of 2 milligrams. That's it.
Yeah.
And so, I mean, that is a very dedicated, understanding patient who understands what that means and what that looks like, and was, expecting pain, and everything was set up perfectly for me. But, so that's kind of where I lean now. It's not my first patient I've done Suboxone post-op for now for orthopedic things, and they've worked well both times.
The one thing for me, it's like if somebody's in the hospital too, and if they obviously went through withdrawal from alcohol, boy, that's going to really, they come in for an orthopedic thing, break their hip, they go through alcohol withdrawal, you send them home with opioids. Boy, that's a tough one. And, I would be doing everything I could not to, based on the fact, they're drinking a lot. Plus, a lot of times they don't really well quantify what they're drinking, even if they don't go through withdrawal, right? They tell us a number that we want to hear. And so, yeah, I'll have to look around. I didn't see much when I was putting this together, but that's a great thought.
In terms of that question, I misspoke a little. I didn't use Suboxone. I just used Subutex with the plain 2 milligram buprenorphine. And I did that versus, you can't really use a Butrans or Belbuca because that's long acting. And so the only option is, just the plain buprenorphine product. Anybody can. It's just being very careful that it's documented well in the rare event that the DEA were to show up.
Yeah. There's a question about can NPs prescribe Suboxone off label?
I just said.
Yeah. Oh, I'm sorry. Never
No,
mind.
I just had to make sure you document
it
a lot.
The question is, would you have to have a waiver also?
I know that you don't need to have a waiver to do like a Belbuca or a Butrans or any of those products. Most patients that have, a couple of patients, or I've had questions, can I do buprenorphine or Suboxone or Subutex, whatever, for pain, have come from people who are waivered. And so I have no idea the answer to that question, because you can use the others without the waiver.
I want to get rid of that. We can turn that off. Okay.
So
any other questions or thoughts before we go? We don't need to do the second patient. That's fine. Otherwise, we'll let people 7 minutes early. The next case would take well more than that. So, all right, everybody.
One thing I was going to say is it sometimes depends on their insurance if they have OUD and chronic pain.
Yeah.
If you put it under the OUD diagnosis, it's covered.
Yep.
And if you put it under the chronic pain, it's not.
Yep.
Right, yes.
If they have both, I always go with OUD for the diagnosis. Yeah.
Right. And that's like, Dave, that's hard because like I wanted this, my post-op people to have it covered. So I got away with it, just substance dependent or chemical dependent.
And opioid dependence is a perfectly good diagnosis because you're not saying that they're abusing it or anything. They've been on it. They have tolerance. They go into withdrawal.
Yeah.
They have dependence.
Yeah.
Yeah. And so insurance is, knock on wood, have so far covered that. Even for the Subutex type or Suboxone type product. I'm sure eventually they'll catch up and try to cover it, but right now they're covering it.
It's only a matter of time. All right. Well, we will let everybody get on with their week. We'll see you next week. We're going to have Charlie talking about the stuff you clean your computer keyboard with and how people are unfortunately misusing that. So
new huffing product.
The new huffing product. So come back for that next week.